And so this was the primary thrust of our guideline when we put this together, to really make sure that women were fully aware of blood pressure. This is such an important issue, and it is by far the most modifiable risk factor for stroke, whether or not you've had preeclampsia. So oral contraceptives are also associated with stroke in young women. And there are a lot of people out there, a lot of women out there who are using oral contraceptives. And this is old data. I'm sure it's more than 10.7 million now. But what I want to point out is that there is a very, very, very low risk of stroke in the youngest age group here, from 15 to 19, 3 per 100,000. This is a really small group of women who might have a stroke here. But it increases 20-fold by the time you get into your late 40s. So if you're still using oral contraceptives, so let's just say the risk of stroke increases by 2-fold. So here it goes from 3 to 6.8 per 100,000. Here you're looking at 64 to 128 per 100,000. So this is a much more significant doubling if you think about it in terms of absolute risk. And so the data I'm showing you is from a population-based study in Denmark, where they were able to get pharmacy records and link it to outcomes in the Danish hospital records. And so they found that essentially the only formulation of contraception that had no risk whatsoever were the progestin-only pills, or an IUD that had no hormone associated with it. But pretty much everything else was a 2-fold risk, and I'll show you some data on the next slide. But even the vaginal ring seemed to have some risk, and the transdermal patch, not used often, but this is something that's probably not used much anymore, because it was thought if you put the hormone in the skin and absorb it that way, that you wouldn't activate the liver and all the coagulation pathways that are associated with oral contraceptives, but doesn't seem to matter. So oral contraceptive patch is not good. But basically, if you look at this far right row here, just to see that the trend is generally somewhere between 1.5 and 2 point something as far as the hazard ratio for developing an ischemic stroke on all these different types of estradiol doses, as well as the types of progestin. So the other thing that's really important with oral contraceptive use is that some risk factors actually accentuate the risk of ischemic stroke if they're present in oral contraceptive users. So we all know that smoking and hypertension is obviously a bad idea for women who are using oral contraceptives. But what this study from the Netherlands showed is that women who are obese can still see an accentuation of risk here, a synergism for oral contraceptives and women who are obese, as well as hyperlipidemia. So these are 11-fold risk for a woman who is using oral contraceptive and has hypercholesterolemia. So this is really important, and what it shows is that these risk factors need to be recognized, and these are young women. And this is a case control study, so the women have had a stroke or not. They're matched to young, age-matched, healthy women. And so there was a huge difference in the risk of stroke with hypercholesterolemia in this population. And so our recommendation was that because hypertension itself is such a big problem with oral contraceptive use, that women should at least have their blood pressure checked before they start. This is actually more of a problem in developing countries where hypertension is very under-recognized. And then if they start a woman on oral contraceptive, they're at risk for developing a stroke right after that. So this is just a really basic recommendation for checking blood pressure. And then other risk factors, as I mentioned, cigarette smoking, prior thromboembolic events, hypercholesterolemia, and hypertension, also important. And if those risk factors are present, seriously consider discontinuing oral contraceptives or aggressive therapy for those risk factors. So just to talk a little bit about menopause and hormone therapy, because this is also something that's been shown as a risk factor for stroke. And I'll illustrate this with another case. So this woman I met when she was 58. She had a history of type 1 diabetes and wore an insulin pump most of the time. And she'd had diabetes since she was in her 20s. Very healthy appearing, though. She takes an 81 milligram aspirin daily. And she developed multiple brief episodes of diplopia and vertigo over the course of a few weeks. And she wasn't sure what it was and went to see her doctor, and she ordered a brain MRI. And not sure how well this shows up, but she had these little tiny subacute cerebellar infarcts. And so this was concerning. So she was evaluated as an outpatient. This is her FLAIR imaging, and I just want to point out that for a relatively healthy woman, despite her diabetes, she did have some white matter changes and some atrophy that I thought was a little unusual for her age. So what happened next is that this is all before I met her. She had a workup with CTA, no evidence of a vasculopathy, but she did have evidence of a PFO, patent foramen ovale, and so she had this closed, as it turns out, before I saw her, and she was on aspirin and Plavix. She had had a hematologic workup sometime before this, but definitely again after the stroke, and she did have a positive lupus anticoagulant and the confirmation test, and she had a very mildly positive beta-2 glycoprotein 1 IgG. And so these are risk factors for ischemic stroke, especially if both are positive. And she also said, oh, by the way, my husband has early onset Alzheimer's disease. I'm really stressed out. I kind of stopped taking care of myself for about 18 months. And her hemoglobin A1C went up to 8.3. So she was definitely not controlling her diabetes as well as she should have. And then she says, oh, by the way, I'm taking Premarin. And this was not on her medication list. And so unbeknownst to her primary care, she had forgotten to mention that she was taking estrogen. So this is something that she'd been doing because she had early onset menopause in her mid-40s. So she had no other family history, but altogether you have this woman with diabetes as a risk factor, but otherwise healthy. She has some hematologic tests that are abnormal. She has a PFO. She's had some embolic appearing strokes. And so then the question is what to do next. Sorry. Obviously she's on aspirin and Plavix because she had the PFO, and this is something that they recommend for at least 6 months after. And then ultimately I did repeat her antiphospholipid antibody testing, and it was all negative, which was reassuring, and I didn't feel that I needed to change her antiplatelet therapy. So interestingly enough, she asked me if she could stop her Plavix because she was just tired of taking it, and her cardiologist said it would be okay. And so she stopped her Plavix, and 2 weeks later she had the same episodes. And she ultimately came back in and had an MRI that showed something similar to what I showed you earlier. So a couple of really small infarcts, nothing that's causing lasting damage, but of course that was very concerning to her. So I put her back on the Plavix. It's possible that she could have aspirin resistance. But otherwise I did get her off of the estrogen too, in case you were wondering. So a very interesting story about all the different risk factors. The other thing I point out is that she did have early onset menopause. In some women, this could be a risk factor for stroke. There are some studies to suggest that as well, but it's not absolutely clear that every woman with early onset menopause is at increased risk. All right, so I'm going to talk for the last bit about outcomes, and this is one of my favorite topics. And so it has been shown through systematic reviews that women are at increased risk for poor outcomes after stroke. And the problem is that the studies that have been done are not all the best in terms of the data quality. And so some of these studies didn't even look at confounders such as age or stroke severity or depression, pre-stroke functioning. These are all really important. And so what we did was use our AVAIL database. So this was a database on medication adherence in a registry of stroke patients. And what we did was measure outcomes at 3 months and 1 year. And what we found is that women, in fact, did have worse outcomes at 3 months. That's in terms of the modified Rankin scale, the PHQ-8, which is depression minus the suicide question, and then the EQ-5D, which I'll tell you more about, which is a European quality of life measure. And the same was true at 12 months, that women had worse outcomes, although they were not more likely to be rehospitalized. And so in terms of the EQ-5D, there are 5 dimensions. It's mobility, self-care, usual activities, pain, discomfort, and anxiety and depression. So this is a disease non-specific quality of life measure. And it happens to work well for stroke because a lot of these are very important in terms of outcome. And so what we found is that the score overall was lower in women versus men. And the reasons why was because women did worse in terms of mobility, usual activities, pain and discomfort, and anxiety and depression at the 3-month mark. And then at 12 months, the usual activities improved. We had mobility, pain, discomfort, and anxiety and depression. So this is probably what is driving the worst outcomes in women. And it could have to do with their pre-stroke function and age, but this is what we were finding with our EQ-5D measurement. And so we did a lot of statistical modeling to try to find out what was really important as a confounder in this outcome. So this is just men versus women. You can see that women had a lower score. And then when we accounted for gender, age, race, and marital status, then the difference between men and women narrowed. And then that was the biggest set of confounders here, was age, race, and marital status. And then even when we added all these other things like income, insurance, and clinical factors, really didn't make that much difference. It's this jump here for inclusion of age, race, and marital status that had the biggest impact. And that was true at 12 months as well. And so what we assume is that any study that does not take into account age, race, and marital status is really not getting at the crux of the difference in outcomes. And this is just if we're going to explore this whole thing about depression a little bit, there is a study, the Northern Manhattan study showed that there are differences in perception of recovery between men and women. So they asked them, have you made a full recovery, and do you need help? And women who are in the highest functional category reported less recovery and a greater need for help than men who are in the same category. So there is a perception that they are not back to where they are, even when they may be in terms of the scales that we use to measure functional recovery. And so depression was associated with a greater need for help. And so if you think about it, women are used to multitasking, taking care of other people. If they're not doing that the same as they were before the stroke, it decreases quality of life. And then the other really major factor, great study from Italy, and they actually matched men and women for severity, age, and the onset of admission to a rehab unit. And when you look at all the different functions here, you can see that women, even when all of these things were controlled at the beginning, that men had a 3-fold higher odds of independence with stair climbing than women, and women had a 1.7-fold higher odds of walking with a cane or an aid. And so there could be some issues with muscle function. Sarcopenia is a big problem with women as they get older. And so this is a major factor for just the physiological differences between men and women in recovery. And so this could be driving some of the mobility issues that we saw with the EQ5D. So I'll just summarize by saying that there are gender differences. I hope I've made that clear as I've gone through the talk today. And the risk scores are really kind of missing some of the important factors that we think could influence the risk of stroke in women. Whether or not they are more important than diabetes and hypertension and hypercholesterolemia, we don't know. But then again, we're not looking at the younger population in those risk scores either. And so the worst outcomes in women, not entirely explained by old age and pre-stroke comorbidity, but certainly their pre-stroke function and their perception of recovery is important, and that we really have a lot of work to do to try to figure out what these differences are in both stroke risk and outcomes. And I'll be happy to answer any questions.